At the beginning, I'd like to thank Dr. Abdudin Chatterjee for giving me this opportunity to present uh, this before such an august audience. I'm going to present a twisting tale of secondary CNS vasculitis. Rarely connected with diseases like lupus or rheumatoid arthritis, present with headache, which ultimately turn out to be CNS vasculitis. So this is rare, very difficult to diagnose, complex and challenging. So we are going to present such a case and the challenges we faced and how we overcome and how we manage the case, and along with review literature we will go. So let's start with the case. Mrs. MC, 53-year-old lady, presented with deviation of mouth towards left along with drooling of saliva for 1 day. She is a old case. She presented to us in 2021 and till then she is following up with us. She was a known case of rheumatoid arthritis for 4 years. When she presented to us that time, she had 4 year history of rheumatoid arthritis. Actually, diagnosis was made 4 years ago, but the inflammatory polyarthritis she was suffering from was 5 years when she presented to us. There was no history of rashes, oral ulcer, photosensitivity, Raynaud's phenomenon, and rheumatoid factor and both anti-HB both were very high. At the time, she was diagnosed to have rheumatoid arthritis. Anyway, she was not even somehow she did not take any proper treatment, appropriate treatment for rheumatoid arthritis. She took hydroxychloroquine and prednisone both intermittently. She was never prescribed rheumatoid arthritis. So her disease, rheumatoid arthritis, was never under control. Before coming to this hospital, INK, she was admitted to another hospital for evaluation of anemia. She had the symptoms of anemia, and there in that hospital, she was evaluated. Hemoglobin was found to be 7.2, serum ferritin was 400, and she was diagnosed to have anemia of chronic disease, and she was given 2 units of blood transfusion. She was discharged, and when she came back to her home, after a few days, she developed deviation of mouth. These symptoms that she presented to us. She developed deviation of mouth for the left side along with drooling of saliva, and she was unable to close her right eye. And with these symptoms, she was admitted to our institute here in February 2021. She also complained of mild headache for last 3 months. It was a global headache. It was continuous, and she took operation paracetamol with modest relief. There was no history of fever, unconsciousness, seizure, or limb weakness. And general examination, apart from hypertension, nothing was contributed. I mean, nothing was significant. The image is the image is not coming. I don't know why, but anyway, it was showing that Bell's phenomenon. She had right-sided facial nerve, lower motor neuron palsy, and she had typical Bell's phenomenon kind of thing. I can show you later. Yeah, this one, the upper one. She presented with this image. Okay. And planters were bilateral equivocal, deep linear requests were normal, and other neurological examination like motor systems, the systems were within normal limits. And the MSK examination showed a lot of tender and swollen joint. Also, she had deformities in the form of boutonniere deformities and swan neck deformities. You can see one swan neck deformity here, and the rest of the image is not showing. So there was some boutonniere deformities as well. And there was rheumatoid nodule at the elbows on the both olliferative processes. CDI was 26, SDI was 28.7, depicting she had very high disease activity. Bilateral temporal arteries on examination were normal. Other systems were normal. So initial investigation showed high ESR and CRP. And all other investigations were normal except USG whole abdomen showing splenomegaly. Now MRI of brain was done as a part of evaluation of 7th cranial nerve palsy. So MRI showed periventricular hyper intensity here and some other areas also. Basal ganglia hyperintensity and also subcortical white matter hyperintensities. Hyperintensity was shown in the posterior circulation as well. But the MRI of cervical spine was normal. So up to this, I think we should pause a little bit. What would be our thought process, or what are the differential diagnoses?
Any input from the floor is welcome.
Dr. Shyamashish, this was our case, and I think we published this case. She did not have any seizures, right?
No.
She did not have any seizures. So there was some hyperintense lesions in the subcortical area. It was long back, I have forgotten this. But there was some hyperintensities in the cord, possibly in the cervical cord also, right?
God was not there, no?
It is here.
Yeah.
Very subtle.
Very subtle. So somebody would initially think that whether the patient has got some sort of the odd kind of demyelinating diseases also, like emoji antibody disease, some sort of NMO antibody disease also. So those will be also in the list, like the neurologist will say. So we had retrospectively, those tests were done and they were negative, which you have not mentioned. The NMO and emoji was done and they were negative.
Interestingly, if you think for the secondary vasculitis in reference to connective tissue disease, rheumatoid arthritis is usually not in the top of the list. Because we come across systemic lupus, Sjogren's, and mixed connective tissue disease. These are coming in the top. Rheumatoid, vasculitis, yes, we come across in a devastatingly advanced rheumatoid with a very high rheumatoid factor of CCP and skin infarct. That's the usual phenomenon. CNS manifestation in the setting of rheumatoid is usually not a usual picture, and as Dr. Ghoshal was suggesting, the other differential in reference to demyelination associated with rheumatoid also will be close mimicked. So any other input, otherwise Shyamashish can progress. Yeah.
So these were the differences diagnosis suggested by our radiologists. First one, edema. Because as Dr. Nirmal Ghoshal was mentioning that there are subtle hyperintensities as cervical cord also, that was part. And multiple sclerosis or NMO spectrum disorder, but thing is that there are some gray matter involvement also that goes against that. Press, posterior circulation involvement, though this was not very typical of press, the image was not very typical of press, and definitely vasculitis, fourth differential. CSF study was done. Protein was 60, slightly raised, and all other tests including gram stain, Zn stain, fungal stain were negative, no oligoclonal band. CSF, anti-MOG and anti-alpha-4 antibodies, NM antibodies were negative. Immunological tests were performed. RF was 360, IgG 1050, CRP was 24. ANA was mildly positive with DFS pattern. DFS pattern is usually non-specific. It is usually not associated with any kind of connective diseases. And ANA profile was normal except borderline positive I was not P. Complements were normal. MPO and PR3 antibodies were negative. So, because CNS vasculitis, secondary CNS vasculitis was our differential, we went for DSA of brain. And that showed bleeding pattern of the MCA, ICA. You can see the bleeding pattern here, the stenosis, here focal stenosis, here, and bilaterally in the AC also, AC and MCA, and also posterior circulation. You can see from this view also you can see a lot of stenosis followed by posterior dilatation, which is called bleeding pattern. You can see a lot of bleeding pattern. The DSA you can see. So, yeah, DSA. This was the report, and DSA showed bleeding pattern in distal branch of anterior cerebral and posterior cerebral artery. So our final diagnosis was CNS vasculitis secondary to rheumatoid arthritis. So In rheumatoid arthritis, CNS vasculitis is rare, estimated to be 1 to 8%, and in literature only case reports are available, no case series. And the affected arteries are medium-sized vessels. Pathologically, they are similar to polyarteritis nodosa. Clinical features: the presentations are headache, mental status changes, cognitive decline, seizure, cranial palsy, paralysis in the form of hemiplegia or paraplegia in case of involvement of spinal cord, intracranial hemorrhage. Fever is typically not present. In most reports, patients with CNS vasculitis secondary to RA had long duration of erosive seropositive rheumatoid arthritis with rheumatoid nodules and sometimes skin necrosis also, as Professor Logan was mentioning. And treatment is similar to primary angiitis of CNS. Now, this criteria we use for primary diagnosis, primary CNS vasculitis, this famous Calabrese criteria. And till now we are using, though there is some new proposal of newer criteria that has been presented by my previous speaker, but still the established criteria is this one. We are using for this for secondary vasculitis, secondary CNS vasculitis. So there are three criteria. All criteria has to be made for primary CNS vasculitis. First one is recent history or presence of an acquired neurological deficit of unexplained by other causes. Second, evidence of vasculitis in a CNS vascular specimen or a cerebral angiogram with changes characteristic of vasculitis. The third one, we explore other causes of secondary vasculitis, which is not relevant in this case because we are going to diagnose secondary CNS vasculitis. So this patient made actually one or two criteria, first two criteria. So it was secondary vasculitis, CNS vasculitis secondary to rheumatoid arthritis. So CNS vasculitis secondary to other causes can be infection. That we already mentioned. Dr. Monakir has mentioned the varicella zoster arteriopathy affecting brain. This is the most common varicella zoster. Also other virus like CMV, hepatitis B, hepatitis C, HIV, all these things may cause CNS vasculitis like picture. Systemic vasculitis, namely ankylosis vasculitis, Behçet's disease, polyarteritis nodosa, and this primary vasculitis may also present with CNS vasculitis, CNS involvement in the form of vasculitis. And connected to diseases like rheumatoid arthritis, SLE, Sjogren's disease, sarcoidosis may have secondary CNS vasculitis. In ankylosis vasculitis, CNS symptoms has been described in 7 to 11% patients of Wegener's gallbladder or GPA, and 1 to 8% patients with Church-Strauss syndrome or EGPA. And radiographically, verified vasculitis of CNS in ankylosis vasculitis is fewer than 2% of patients with Wegener's gallbladder or GPA and 4% of EGPA. And usually, these ankylosis vasculitis patients usually have evidence of active vasculitis elsewhere apart from this CNS involvement. Behçet's disease neurological symptoms arise in 5 to 14% patients of Behçet's disease. There are two groups, parenchymal group or non-parenchymal group. In parenchymal group, meningoencephalitis predominantly affecting the brain's stem is observed. In non-parenchymal group, thrombosis within the dural venous sinus from stroke due to arterial thrombosis, idiopathic intracranial hypertension, CNS angiitis. CNS angiitis event is very rare in Behçet's disease. SLE, neuropsychiatric manifestations of SLE, who present the patients who of SLE present neuropsychiatric manifestations. In those cases, we can suspect CNS vasculitis if it's appropriate. That means if there is infarct, especially bilateral cerebral infarct is there, then CNS vasculitis or multiple ADRT areas of infarct is there, multiple areas of demyelination is there, then in the background of SLE, we have to suspect CNS vasculitis. Majority of neuropsychiatric manifestations are mediated by T cell and autoantibodies, and they cause damage to the neural tissue. CNS vasculitis is rare in patients with neuropsychiatric lupus. 7 to 10% is the prevalence from post-mortem studies. MRI, brain, and angiography in the form of MRA and DSA are useful to confirm CNS vasculitis secondary to lupus. And in DSA may give false negative result because in most of the lupus patients have predominantly small vessel involvement. And in SLE vasculitis and APS, antiphosphate syndrome must be differentiated because both may present with infarct, cerebral infarct. So this must be differentiated, and in all patients of SLE where we are suspecting CNS vascularity, we have to go for APLA profile, and we have to show that it is negative before diagnosing a case of CNS vasculitis in SLE. And also, in case of CNS vasculitis, other features of active glucose like leukopenia, anti-DSDNA, positive in high titer, and hypocomplementemia has to be there. So, how do we diagnose CNS vasculitis, be it primary or secondary? What is the algorithm? First, the clinical history and clinical features. Then, positive MRI suggested CNS vasculitis, that is infarct affecting bilaterally, affecting both gray and white matter, and maybe SWI showing features of microhemorrhage. If that is there, then we will proceed. We'll suspect of CNS vasculitis, and then proceed for CSF, which and if CSF is also suggestive of CNS vasculitis, this protein or cells are raised, then we have to go for MRA. If MRA shows large, medium, or small vessel involvement, then if there is large or medium vessel involvement, we have to go for angiography. And if angiography shows bleeding pattern, which is typical of vasculitis, then we may or may not go to biopsy, brain biopsy, or we may directly go for treatment itself. Or if there is involvement of small vessels, as suggested by MRA, we directly have to go for biopsy, because BSA is not going to reveal anything in terms of small vessel involvement in CNS vasculitis. So with the biopsy, we can have definite diagnosis and we can proceed for treatment. Diagnosis CNS vasculitis is basically a diagnosis of exclusion. We have to exclude the things like infection we have already described. Now, how imaging helps in diagnosing or confirming CNS vasculitis, primary or secondary? MRI, vessel MRI, or angiography. We have already discussed. I think we should skip MRI. Yeah. What are the typical features of MRI of brain in CNS vasculitis? Multiple infarcts in multiple vascular territory. This is the most important thing when we should suspect CNS vasculitis. And infarct at an uncommon site like corpus callosum infarct. And also, if the involvement is in both gray matter and white matter, then also we have to suspect. And also, if SWI shows multiple microhemorrhages bilaterally, then also we have to suspect CNS vasculitis. Visceral MRI we have already discussed how it is really helpful. But anyway, DSA is confirmatory. DSA is confirmatory. And classical DSA picture is segmental narrowing referred as bleeding, especially of medium-sized vessels. Involvement occurs several sites, usually occurs multiple territories bilaterally. And there is circumferential or eccentric vessel irregularities may be seen. So here you can see bleeding pattern here. From not this patient, from other patients we have taken the image, but our patient only. You can see bleeding pattern here. There may be some other bleeding patterns. Yeah. Now CSF study. CSF usually is abnormal in CNS vasculitis, and cell count more than 5 or protein in CSF more than 45 mg per dl. Usually are present in patients with CNS vasculitis. Oligonucleotide band may be found occasionally, and that will confuse the situation. Viral markers must be negative, and pyogenic and tuberculous infection must be excluded. Brain biopsy is gold standard, though it is done infrequently in CNS vasculitis patients. And a meta-analysis revealed that the diagnostic yield of brain biopsy, meningocortical biopsy, in CNS vasculitis is 74%. So at least 25% patients will be negative for brain biopsy. And usually 3 types of histopathologic findings are found in brain biopsy CNS vasculitis patients: giant cell, granulomatous inflammation, necrotic vasculitis, and lymphocytic vasculitis. So, depending upon the clinical radiological picture, 6 types of CNS vasculitis has been described. There was a primary CNS vasculitis, And the mimickers of serous vasculitis, angiographically, these 4 things we have to exclude. Moyamoya disease, Fabry's disease, Sneddon syndrome, and RCVS. RCVS is the most important, that already have been discussed by your previous speaker. The clinical presentation is very typical, thunderclap and watershed cerebral ischemia, that is there, and RCVS is reversible within 12 weeks. So after 12 weeks, if we repeat the MRA or DSA, that will come down. So treatment options, steroids. Steroids is the first line of treatment, and we have to give second immunosuppressive. Cyclosis is the most commonly used drug, and also we have good evidence of mofetil. Here we have used a lot of patients here in this hospital, and we published that we have a series of 26 patients of about primary CNS vasculitis. 26 patients primary CNS vasculitis who were treated with microfluid mofetil as an induction therapy as well as maintenance therapy. From the very beginning, we started with microfluid along with steroids, and those patients are followed up for 2 years. Mean follow-up period was 2 years, and there was significant improvement of modified Rankin score at the end of 2 years. And microfluid mofetil showed significant steroid-sparing agent, significant steroid-sparing effect, and serial DSA, repeat DSA showed improvement of that vasculitis change, that is bleeding pattern. So that thing was there. So microfluid mofetil, according to our experience, was good for CNS vasculitis. So we according as per our experience, we used microfluid to this case. We used our index case, this is the case we are presenting now. We used this patient with microfluid mofetil, and we started with methylprednisolone pulse for 5 days, followed by oral prednisolone, and started with microfluid mofetil. And for treatment, rheumatology is continuous sulfasalazine and hydroxychloroquine. And this is the image. This one, the patient presented with left-sided element type of Sevenna palsy, cranial neuropathy secondary to CNS vasculitis from rheumatoid arthritis. And MRI was showing some hyperintensity, subcortical hyperintensity there. And after treatment, after 1 year, the patient that improvement was there. Sevenna palsy was no longer there. And also, MRI showed resolution of most of the lesions. So this was our case. Now take home message is secondary CNS vascular rare disease. High index of suspicion is required, otherwise we will miss the case. We have to exclude clinical, especially infection. MRI gives the clue. Bilateral lesions, gray and white hyperintensities, as well as SW showing microhemorrhage. HLOL MRI is very helpful, but TSC is confirmatory, but we have to be cautious about the pitfalls. Brain biopsy is gold standard. If required, we have to do, especially if there is only small vessel involvement. Because DS will be negative in those cases. In absence of brain biopsy, clinical plus MRI plus CSA plus DSA results is useful to perform the diagnosis as we did in this case. And aggressive immunosuppression is required. So with this, I will finish. Thank you.
Thank you for excellent talk. Now we want to hear expert opinion from the floor. Yossi, please, your fingers are closed.
So, as I said in the last discussion also, that you need to rule out other causes of vasculitis before labeling it as a primary CNS meningitis. So, obviously, that workup needs to be done. The clinical context becomes very important. You have to see the patient, observe the patient for any obvious rheumatological manifestations, ask for rash, photosensitivity, joint pains, and things like that. And also, I think they have highlighted, that's what I think Ashish was mentioning about this, the use of mycophenolate alone, this PEPA. So I think in a given case that makes, kind of a case that you might treat these patients with less aggressive, so-called inverted comma drugs. But, the recommendation is that you go initially at least go ahead with a full immunosuppression with a steroid and cyclophosphamide. But I think if this works, I think this will also be a good choice for many patients who cannot really afford that much treatment, or there are other logistical issues for that kind of treatment. The third thing is this, that obviously you need to have a high index of suspicion, because many of these patients may not come to you they may just come to with headaches, right? And if you don't do right kind of imaging, you will miss this small infarcts and small white matter hyperintensities, and therefore you will not be able to proceed further in the investigation, stair. So therefore, I think a right kind of index of suspicion is very important. A young patient present with unresponsive headaches, and that can be having a phenotype of migraine or a tension type headache, right? So don't get. So whenever I say I see the presentations, mostly people mention that headache, but they do not phenotype it, right? It is useful always to have a phenotypic characterization of that headache, because then you will know that even the migraine can manifest, because they are using the same pathways, right? So therefore, I think that suspicion needs to be there, and obviously, as I often say that headache is such a thing that it encompasses the entire internal medicine and the general medicine with a lot of overlaps with many conditions, and you can always be surprised later on to find a secondary diagnosis for the headache. So you need to work on that.
And the DSA only is suggestive of vasculitic pattern. Otherwise, the whole picture in the MRI is, I think, is a secondary demyelination, because the MRI picture doesn't show anything of vasculitic infarct, or rather, there was no hemorrhage.
Gray matter involvement also.
Now that can happen in secondary demyelination as well. But so rheumatoid arthritis presenting with primary CNS and CNS angiitis is a very odd diagnosis. Only the thing was that the DSA was suggestive of bleeding pattern. Otherwise, this secondary demyelination can all explain the headache, the focal deficit, and the MRI picture present with hyperintensity in the white matter as well as in the grey matters. There was no GRE or SWI feature suggesting of hemorrhage, no? Nothing.
SWI is not available here, but it was there. Microhemorrhages in the SWI was there.
As I remember, because this,
I agree fully with you. At times it becomes very difficult to, kind of this thing, and probably will go I would prefer not to use any term. I would say that T2 and fair hyperintensities in a subcortical, and if there are cortical. So if there are cortical, as you were saying, lesions, so then that would raise the possibility that we might be dealing with something vascular. But without being committed to that, this is demyelination. Radiologists have a habit of writing something like ischemic demyelination, right? They often write that kind of thing. So it doesn't really gives us a kind of a right kind of idea that what kind of disease we are dealing with, right? So therefore we need to do, and I think that vascular imaging becomes then imperative for this kind of patients.
Yeah, basically there was grey matter basal ganglia involvement also. I have shown in the image. You can show the image also. To that. So basal ganglia involvement was also there, hyperintensity in there. So that was not actually fitting with typical demyelination. So that's why we went for DSA, and so that's how it came.
As far as I remember, because this case was primarily admitted under me, so there was some patchy meningeal enhancement also in this case, and then in the SWI there were microhemorrhages. So that was the clue, because of which we went for. We also thought for the demyelination, as we had excluded the NMO, MOG, the CSF study we had done. So Dr. Shyamashish, I had two questions. Like some of the rheumatological diseases, they have got higher propensity to develop this vasculitis. But see the rheumatoid arthritis, that has got the, as per the literature as we have searched, it shows that less than 2% of patients usually from this rheumatoid arthritis might have the chances of developing CNS vasculitis. So why it is so? And the other point is that you have shown that large series. How would you follow up with the DSA? Means what is the time frame that you would do the repeat DSA? Because DSA is an invasive test and you would not do it frequently.
Yeah, because we have done repeat DSA in nearly 17-18 patients treated with primary CNS vasculitis, not in this case. And at 1 year, approximately 1 year, we think is a reasonable time period to see the changes in DSA.
for 1 year.
So out of all the rheumatological conditions, which one you are seeing the most having a CNS, secondary CNS vasculitis? Rheumatoid, SLE.
Professor Ghosh already has made it. It's SLE.
So is there any pathology for which they are more prone and rheumatoid arthritis is less prone?
No,
Just just a small question. Is all these secondary vasculitis like SLE, Sjogren, all these can present as a vasculitis or a CNS manifestations without active disease? Means I said the rheumatoid is not clear, but vasculitis I am seeing. Or SLE like those. Can
Right. In the setting of quote-unquote connective tissue disease, primary presentation as CNS impact is very unusual. So, looking through the CNS manifestation, trying to diagnose the underlying background CTD is very, very unusual. And other way around, if you list lupus is the topmost, MCTD, Sjogren's disease, not Sjogren's syndrome, and rheumatoid as Shyamashish has shown is the lowest in the list. And because of its immune mechanism, rheumatoid affection primarily as because the synovial pathology is the primary impact. So the CNS, the vascular pathology, whereas in lupus, the both the T and B cell crosstalk, it targets the vascular simultaneously. So CNS manifestation is topping the list usually of the secondary complication.
But how common is it that you see a disease which is there, but it's not been so symptomatic for the patient to present? Because we see, I think I've seen fairly a large number of patients who are not, rheumatoid. There are manifestations we diagnose, but the patient is not going to the doctor. The patient are not seeking the treatment. Similarly for SLE.
Now, why rheumatoid going to neurologist?
No. Not rheumatoid. Rheumatoid patient coming to me with a neurological complaint.
Achha.
But then I see that there
The
are
joint is squishy.
yeah. And I ask, and then they say, no, it's there, and what is his behavior like? I see no this kind, so-called confusion patients not seeking that much of active treatment.
The usual standard dictum for rheumatoid is when it presents with vasculitic manifestation, rheumatoid is very aggressive, rheumatoid factor antecessive is very high. In that setting, usually presents with a vasculitic complication, be it neurologic, be it peripheral nerve system or cell. Otherwise, and on the other hand, when we see patients with very high rheumatoid factor, very high anticessivity, no joint manifestation, we were hawks, it ultimately turns out to be ANCA-associated vasculitis later on. So 6 months, 1 year down the line, they were not rheumatoid, but they were the heralding autoantibody predictors for the vasculitis ANCA-associated. So that may be a component. Yeah. Thank you so much. Now we can close the session.
Thank you, our esteemed panelists.